It's still fuzzy. There we go.
This is the last full lecture, well, the last lecture in positioning for this semester. We'll have a final exam for lab next Monday. And your lab practicums will be Wednesday and Friday. And we'll be done with positioning for this semester. So this bony thorax, you're not going to be taking a whole lot of exams up bony thorax, maybe occasionally some ribs, but they are still registry testable, so we're going to have to cover them. So some of these things, in all honesty, I've never shot my entire career, and I don't know that any of the faculty would say that they had. But occasionally you shoot sternum, sometimes ribs, but the rest of what we're going to talk about today, you just need to hang on for the registry, hang on to for the registry, and you may not ever shoot them. So the ribs, or the bony thorax, is formed by the sternum. You got 12 pair of ribs. So we tend to not refer to them as individual, but rather in pairs. So as far as bones go, you got 24. And in some patients, you remember talking about cervical ribs. I have accessory ribs as well. So some patients will actually have 13 sets of ribs. That's pretty rare, but it does happen. You got the same number of thoracic vertebrae as you have ribs, so you got 12 of those. The thoracic cavity is conical in shape. That means cone shape, and it's narrow at the top, broader at the bottom. It's posteriorly, it's longer than what it is on the anterior surface because of the dome of the diaphragm. If you remember, the posterior portion is longer than the anterior portion. So what does it do? It serves to protect all your vital organs, or the thoracic organs anyway. So it protects your mediastinal structure, protects your heart and your lungs. It supports the wall of the pleural cavity and the diaphragm. And it is, without the ribs, you wouldn't be able to breathe. Because what happens whenever you inhale is that diaphragm drops and creates a vacuum. And if you didn't have ribs, then essentially your chest would collapse and you wouldn't breathe. As diaphragm dropped, the vacuum would draw the medial and lateral and posterior and anterior portion of the thoracic cavity in. And nothing would happen except for collapse of the chest and expansion of the chest. So they truly assist in breathing. With the intercostal muscles, they lift and separate and exaggerate that negative pressure, and you can breathe very well. So it supports the wall of the pleural cavity and diaphragm. It's made to vary the volume of the thoracic cavity during respiration, which is just what we're referred to. It keeps the pleura in the lungs inflated as the diaphragm drops. The intercostal muscles lift and separate to help you breathe. So they look like that. T1 attaches to the first set of ribs. Remember, you've got those costal facets on both the transverse process and the body, and that's how we determine, just by looking at a vertebra, whether or not we had a thoracic vertebra. So that anterior aspect, notice that the ribs don't go all the way to the manubrium or all the way to the sternum itself. What we've got is costal cartilage here, so our anterior ribs stop just as they become anterior ribs. And you don't really have a direct connection. You have a direct connection, but a direct connection through the costal cartilage. So sternum is centered on the midline of the anterior portion of the thoracic cavity. It's a flat bone, so it's a red blood cell producing bone. And I've not witnessed this myself, but I have talked to people who have witnessed somebody as a bone marrow donor, and the doctor actually putting a needle into this person's chest to draw some of the bone marrow out. Any flat bone is a red blood cell producing red marrow containing bone. All right? So skull, pelvis, sternum. If you need a bone marrow transplant, I'm gonna be really, really hard pressed to let somebody stand on the table that I'm laying on and pierce my sternum with a needle in order to draw my bone marrow out to give to you. Love you, it ain't happening. Because what's right behind the sternum?
Heart.
The heart, right, it goes through the sternum and you got a problem. So it's a narrow flat bone, it's approximately 6 inches long, and it's got 3 parts, and that's a manubrium up the top. This broad portion up the top is the manubrium, and then at what we call the sternal angle, it attaches to the body, and the xiphoid processes all the way down at the bottom. So it supports the clavicles at the manubrial angles. It forms the sternoclavicular joints, and we'll talk about imaging of the sternoclavicular joints later on. And it's the sternoclavicular joints, remember, are the only bony union between the upper extremity and the trunk, right? So everything from clavicle out is considered upper extremity. And that little spot right there is really our only attachment between the entire upper limb and the trunk itself. So it also provides attachment for costal cartilage, which in turn provides attachment for the ribs. So the manubrium has the upper portion, the broad triangular upper portion. The jugular notch is a palpable landmark, and that's where you poke on your sternum, and then all of a sudden you poke, 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 like that. Right there where it sinks is your jugular notch, and that lies at T2, T3. So the body is the longest portion, long, thin portion, and it's joined at the manubrium, joined to the manubrium at the sternal angle, and also you should be able to palpate that as well. So you find your sternal notch, and you go down a little bit from that, and you can, in a lot of cases, feel just a little bit of a bump, right? And that's where those two are fused together. So it's palpable, and it lies at T4, T5. And the xiphoid process is at T10. And sometimes it's not centered up quite so well, so it often deviates from midline just a little bit. The ribs, again, you've got 12 pair, and they go from top to bottom, 1, 2, 3, 4, and so forth. So they're long, narrow, and very curved. And since it's not a ring-type bone, you know, it doesn't really have a firm, solid attachment at the anterior portion. The ribs kind of break the rule that if you've got a bone that's got a steep curvature to it, that if it's going to be broken in one place, it's going to be broken in two. You can break your ribs in a single place, as opposed to the jaw, as opposed to the pelvis, the anterior pelvic rings. You can break the rib in just a single place. So the anterior end lies lower than the posterior end, and we took a look at that whenever we were taking a look at chest x-rays. We counted. We could always count the ribs because the anterior ribs were, for the most part, at a downward angle, as opposed to the posterior ribs came directly off the vertebra itself. So the varying length and breadth, first is shortest and broadest, and then it increases in length from 1 through 7, and it decreases in length all the way down to 12. So they're classified by attachment. The first 7 are true ribs, and that is because they've got a direct attachment to the sternum through the costal cartilage. The false ribs are 8 through 12, or they're really 8 through 12. We usually say 8 through 10. 8, 9, and 10 are false ribs, and 11 and 12 are floating ribs. But what makes them a false rib is that they don't have a direct connection. So their costal cartilage connects to the costal cartilage of the 7th rib, and that in turn connects to the vertebra, or to the sternum. So going back up here, you see you've got 1, 2, 3, 4, 5, 6, and you got direct connection here. But you've got indirect connection from 8 through 10. It connects right here to the same costal cartilage that comes off of the 7th rib. So true ribs, false ribs, really all of them are false ribs, but we usually subdivide false ribs into false ribs and then floating ribs, and floating ribs have no attachment anteriorly. So a typical rib has a head, a neck, tubercle, and a body. We're not going to spend just a whole lot of time on that. We're going to look at a diagram of a rib, but we're not going to spend just a tremendous amount of time with it. The head articulates with a vertebral body, and that's what forms your joint space, that facet joint on your vertebrae. So tubercle articulates with the transverse process, and it looks like that. So you got a facet joint, got a head, a neck, an angle, and then the body is the longest portion that extends anteriorly. All right, so a lot of our positioning for a set of ribs is going to sound an awful lot like positioning for chest X-ray. So anything that's going to cast an artifact needs to come off the patient. It's probably more imperative here than what it is even in chest X-ray. In chest X-ray, if the patient has on a shirt that's got maybe a pocket on it, you're going to be using such high KVP, you're probably not going to see the pocket. But whenever we do ribs, you're going to use a lower KVP. A lower KVP, you get less penetration, and you get a shorter grayscale and higher contrast. So I'd really, really recommend that you just go ahead and dress the patient. Just go ahead and take everything off the patient and put them in a gown, preferably a gown without snaps. And if they do have snaps on, just make sure the snaps are up on the shoulders. So dress your patient. If the patient's wearing anything with buttons, certainly dress the patient. If they're just in a regular t-shirt, then that's probably going to be okay. But if it's got any kind of paint or anything like that on it, just go ahead and, put them in a gown. Again, we're going to have a lot of positional pain with the patient with the possibility of broken ribs, and it's kind of like what we talked about in shoulders. If the patient's upright, go ahead and shoot them upright if at all possible. If the patient seems to be a little bit short of breath, maybe put them on a stool, but make sure it's not a rolling stool. Ribs, a patient who truly has a broken rib, the pain is pretty lingering. It goes on and on for a long time. The patient can't breathe real well. Because, you think about any other broken bone and you can immobilize it, right? The patient's got a broken foot, you can put them in a boot, right? The patient's got a broken arm, you can put them in a cast. The patient's got a broken rib, and what do the ribs do? They lift and separate whenever you're breathing, right? So if they're lifting and separating, how are you going to stop that? I guess you could concentrate really hard on and just breathe through, lowering your diaphragm. But you really can't stop it. So what happens in a lot of cases, and the danger of ribs are two things. Danger of broken ribs, two things. And neither one have so much to do with the rib itself, but what the rib causes. Number one is that the patient can't get a good deep breath because of the pain, or they won't get a good deep breath. So sometimes the patient will develop a pneumonia secondary to the broken rib. The rib didn't cause the pneumonia, but the patient's inability to breathe sometimes does. And the other thing is, more acutely, is what did the rib do? What did the broken rib do? Did it puncture a lung? In which case we got a pneumothorax. We may have a hemothorax along with the pneumothorax. So the rib itself, it's really no big deal that the patient has a broken rib. It's just what is the broken rib going to lead to? So we talked last week in the test review about the first images that you shoot on a trauma series, and the reason we shoot chest X-ray is primarily for this. The chest X-ray also satisfies the requirement of the ribs. It's not ideal because the grayscale is going to be much longer than what we would like to see on ribs, but again, the danger is not whether or not the patient has a broken rib, but rather what's going on with the broken rib. What they're going to be looking for is, before they even try to zero in on the ribs, is the lung still inflated? Does the patient have subcutaneous emphysema? Y'all seen that? Subcutaneous emphysema is where not only do you have a pneumothorax, but some of that air in a lot of cases leaks out into the tissues, and you can actually see the striations in the patient's muscles. And you can even tell without looking at the x-ray that the patient has subcutaneous emphysema. You touch them and they crackle, kind of like you got a mylar balloon. You know how a partially inflated mylar balloon makes that crackling sound? Patient's skin will do that. It's what they call crepitus. So the first exam that we shoot in a trauma situation, if you called in for a trauma panel, is that chest x-ray. Again, unless the attending physician says he needs something before that, that's always going to be your first x-ray, is chest x-ray. Because it doesn't matter what else is going on with the patient, you know, your basic ABCs, you know, we gotta have airway, we gotta have breathing, and then circulation comes even third to those two things. If the patient's not breathing, they've got minutes to live. If the patient's bleeding, well, we've got a little bit longer to deal with that, right? So, chest x-ray to diagnose all that stuff. And if we have a situation where the patient's got a lot of broken ribs on one side, then we get what we call a flailed chest. A flailed chest is where we've got so many broken ribs that the patient can't breathe on that side. And what happens is, again, it's kind of like not having ribs at all. As the diaphragm drops and it creates that negative pressure, the wall of the chest will sink in, right? So maybe one lung stays inflated, the other lung just collapses whenever you try to breathe. So your lung capacity at that point is about half of what it should be. If they got a bilateral flailed chest, then the only way that the patient's going to get any oxygen is for a breathing tube where you introduce positive pressure. It's a very dangerous situation for a patient to be in with a flailed chest. So everything else is the same. Patient position, depending on the patient's condition. SID. You know, your textbook may say 40 inches, may say 48 inches. In some cases, you may need to do your ribs at 72 inches. And a reason for that is because at 40 inches, because of the divergence of the central ray, sometimes you're going to have a hard time getting the patient on an image receptor. So even, you know, if it's a big patient, even a 17-inch image receptor. So you might, you know, buy yourself a little bit more space by backing up the central ray so that you don't have quite as much divergence of the central ray, right? So I'm not necessarily saying use 72 inches on every set of ribs, but use a little bit of discretion. If you've got a great big patient and you put the patient, say you can't stand the patient up, you put them on the image receptor and you can't see any portion of the image receptor anymore, raise your tube, lower the bed. Buy yourself a little bit more space because that divergence could project the patient off the image receptor. So use your markers, use radiation protection where appropriate. Patient instructions for the most part are, depending on the exam, you can actually do a breathing technique with ribs, but it's got to be very limited. And what I mean by that is, you know, most people are just going to shoot on inhalation. I'll shoot on while the patient's exhaling. So it's maybe a half-second exposure as opposed to like a 3-second exposure you would normally get out of a breathing technique. By a patient taking a big deep breath, slowly blow it out, and while they're blowing it out, make an exposure. And that just provides enough motion in the lung markings to minimally blur them out without blurring the ribs. Some of our other exams, we're actually going to use full breathing techniques for the sternum. Okay, so all that stuff we just talked about. Also, on our sternum, we're going to, almost everything that we've ever talked about, we're going to throw out the window. And we're going to use something different. All right, so what I mean by that is for the sharpest image, what kind of OID do you want?
A small one.
What's that?
A small one.
Small, right. You want smallest OID as possible. And we're going to use that, you know, whenever we shoot a sternum, but we're also going to use a decrease in SID. What does a decrease in SID do to your sharpness recorded detail?
Makes it go up.
Sharpness recorded detail goes down with a decrease in SID, right? So what we want is, you know, is long SID, short OID. We're going to use that short OID, but we're going to use a short SID, and we'll talk about that when we get to it. And generally speaking, we say that the thing that's going to mess up your sharpness or recorded detail the most is patient motion. Well, what are your types of patient motion? Yeah, breathing is type of patient motion. We're going to have a patient breathe through the exposure. So again, we're going to use a low SID, not to destroy the sharpness or recorded detail of the sternum, but rather to destroy the sharpness or detail of the ribs. So the patient, when we shoot our sternum, we're going to have a patient PA. So the OID is going to be very low, right? But we're going to shoot with a 30-inch SID to try to blur out some of the ribs. The sternum is very, very difficult to get a good image on, especially the first time around. Okay? So use your markers, radiation protection where appropriate, patient instructions. Again, we'll hit those when we get to the specific exam. So sternum. All right, so your sternum is, unless the patient's on a backboard and the patient just cannot be moved into a prone position, you're gonna shoot your sternum PA if at all possible. And again, there's gonna be a tremendous amount of positional pain with the sternum. If you've ever taken a good hard lick to the sternum, you know that whenever you bend over, the pressure increases and it gets very, very painful. So move the patient as little as possible, but we are going to have a patient on their stomach. So it's going to be a right anterior oblique, and then we're going to shoot a lateral, either with the patient upright or recumbent. Again, if the patient's already laying down for the oblique, just go ahead and shoot the lateral cross table. All right, so we're going to use the RAO, and what that does is you got your sternum here, and you got your heart. Remember, your heart's at midline, but it's the biggest portion of the heart is towards the left-hand side, right? So the patient's laying on their stomach. So what we've got in the sternum is we've got a very, very thin bone that's going to be difficult to visualize. So what we're going to do is we're going to kind of add the heart as if it was contrast. To increase the density of the sternum itself, or the appearance of the density of the sternum, what we're going to do is we're going to rotate the patient into RAO so that the heart, the shadow of the heart, is projected over the sternum itself, just to add a consistent density as opposed to all those squiggly lines in the lung markings. Okay? So it's a suboblique, it's 15-20 degrees. So just get the patient's arm bent, their head facing in, towards their left, and rotate, have their arm push with their arm, push them up. Put this arm down to the side, their right arm should be down to the side. Have them rotate up just 15-20 degrees. So generally speaking, if you have a patient bend their left knee and just push a little bit with their left arm, they can rotate into 15-20 degree rotation with minimal effort. Top of the image receptor should be about 1.5 inches above the jugular notch. So the central ray is going to enter the posterior thorax about 1 inch lateral to the elevated side of the vertebral column at the level of T7. So where was T7?
Inferior border of the scapula.
Scapula, right. Just like on a chest X-ray, the inferior border is scapula, level of the inferior border of the scapula. So, all right, so you got sternum here, and you've got the spine here. So as we rotate up, we're going into RAO position. What you're going to do is you're going to go about 1 inch lateral, or to the elevated side of the vertebral column, because they should be superimposed with patient PA, right? They're truly prone. So all we're doing is we're compensating for that little bit of obliquity by putting our central ray back over directly over the sternum itself. Okay? So breathing technique to blur the lungs, instruct the patient to take slow, shallow breathing. Again, if they really have any kind of injury to the sternum, they're probably going to be doing that anyway. Just watch the patient and make sure that they sometimes they'll have a tendency to take gasping breaths. Just make sure that they're nice, slow, fluid breaths. And if you can only get, if you're timers will only allow limited exposures, then what you're gonna do is suspend breathing at the end of expiration. Or again, you could do a deep breath in, slowly blow it out, and you get about a half second exposure. So you want collimation, entire sternum from top to the bottom, and the sternum should be projected over the heart. Minimal rotation of the sternum and thorax shown by the following. Sternum should be projected free of superimposition from the vertebral column. A little bit of obliquity to the vertebra. The lateral portion of the manubrium and sternoclavicular joint should not be over the vertebra itself. Your lung markings should be blurred, and your exposure technique, you're going to use a lower KVP so that you can increase that contrast. Make sure you don't process it on a chest x-ray algorithm. Make sure it's on sternum or rib algorithm. So it looks like that. You can kind of see the outline of the manubrium here, and then you've got would be your sternal angle, and then you've got this scalloped appearance here. Looks kind of like a serrated knife, right? That's your sternum. And I can tell you that this is an exceptional sternum. Okay, exceptional is what I'm saying. First time you shoot one, it ain't gonna look nothing like that. Okay, the first time you shoot one on every patient that you ever shoot, it's not gonna look anything like that. The sternum is one of those exams that you're gonna have to shoot over and over again, just to make it show up. So occasionally you'll get it on the first shot, but it's probably, if average repeat rate is 5%, I'd say sternum's closer to 50. Okay, so just understand that if you get a sternum and you make an exposure the first time, you just don't see the sternum at all. Even if you've done everything properly, you know, it's not uncommon. It's a hard image to get in a single exposure. So lateral sternum, again, don't move the position, the patient's position from recumbent to upright. If the patient's already laying down, just flip them over on their back and shoot cross table. So the difficulty in the sternum itself is getting the arms out of the way and getting not even just breast tissue, but the chest tissue out of the way. So what you're going to have to do is, if the patient's upright, if the patient's laying down, for the most part, it's fairly well isolated. But if the patient's upright, what you may have to do is do that whole lateral C-spine thing again, have them put their arms behind their back, straighten their back and their shoulders out, just to protrude their chest out a little bit more. So straighten their elbows out so that it just kind of pooches it out there. If the patient's on a stretcher, I've done this before. If the patient's on a stretcher, you're doing a sternum, then what you can do is set the stretcher up and then put something, a roll of towels or something behind the patient's back and try to get them to put their shoulders as far back as possible. So oddly enough, you would think that the lateral sternum would be easy, but it also, because of all the soft tissue you're going to project over it, is difficult to visualize adequately. So again, top of the image receptor about 1.5 inches above the jugular notch. Get the patient as lateral as possible. Use a 10 by 12 image receptor size. Close collimation so that you can increase the contrast, get rid of some of that scatter radiation. Have the patient taking a big deep breath, and that'll also help to pooch the chest out, and have them hold the breath at the end of deep inspiration. So all that. And it looks like that. Again, that's an exceptional image. Sternums are just very, very difficult to get a good image of. So even the upper portion of the manubrium, we don't see all that well. It looks like maybe some of the soft tissue of the humerus is in the way. But that's as good of a lateral sternum as you're ever going to see right there. Okay, so sternoclavicular joints. We got a couple of different things. I don't know why I didn't follow up with the page number on that, but we got a couple of different projections for the sternoclavicular joints, and that is a PA and a PA oblique. PA is not truly a PA. It's a minimally oblique projection, so that what we're going to see on both of these are the sternoclavicular joints in different places. Okay, so on the PA, what we're going to see is we're going to see the sternoclavicular joints on the elevated side. Again, truly not PA. And on the PA oblique, we're going to oblique the patient enough so that we can see it on the side closest to the image receptor. So on the PA, what we're going to do is we're going to center the image receptor at T3, and we're going to, sternoclavicular joints are always going to be bilateral, but what you're going to do is you're going to have the patient on their belly, and you're going to have them look in one direction, and with their head turned, unless the patient is extremely flexible, with their head turned, the thoracic cavity is, or the thorax, is going to rotate just enough so that your sternoclavicular joints, kind of like, you got manubrium here, and you got the sternum plugged into it like that, almost. And what we get with the turning of the head is enough of a separation between the two so that the spine overlying the manubrium goes in one direction, we can kind of see it. Okay? Does that kind of make sense? So you're going to do both sides. You're going to lay the patient on their stomach. You're going to say, you're going to center it at T3. You can say, I want you to turn your head to the right. And you turn their head to the right, you make an exposure there, and it's very small collimated field. Make an exposure, turn your head to the left, make an exposure, and that rotation of the head just provides enough of a change between the spine and the manubrium so that the manubrium comes out from under the spine just a tiny bit. Okay? So turn the head, face the affected side. It's always going to be bilateral. Turn to the left, turn to the right. Rotation of the head obliques the anatomy just enough to separate the clavicle from the superimposition of the spine on the elevated side. Elevated side. All right, so the side that you're looking towards is the side that you're going to visualize. That's on the PA. PA oblique, though, we're going to rotate the patient 10 to 15 degrees. And what that's going to do is it's going to rotate enough, so we're looking at the sternoclavicular joint, and we're going to rotate the patient enough that, let's see if I can make this happen, so that what we'll see is, that's not working the way I wanted it to. Let's go like this then. So what we're going to see then is the sternoclavicular joint on the side that's closest to the image receptor. Spine goes one way, the manubrium goes in the opposite direction so that we can see the sternoclavicular joint. We get separation of the spine enough to see it on the side closest to the image receptor. Again, bilateral obliques, so you're going to rotate the patient 10 to 15 degrees in one direction to shoot the side closest to the image receptor, and then rotate the patient in the opposite direction, 15, 20 degrees, and shoot the opposite side. Okay? Take the image at the end of full expiration. And we don't even have images for those. I don't think. Let me see. Take it on down. Yeah, let's try it again. No, we want to have images. Okay, any questions on those? Sternum or sternoclavicular joints? All right, then ribs. All right, so we can shoot ribs PA, we can shoot them AP, and if we're shooting obliques, what we're going to see are going to be a little bit different. So we're going to have PA, AP, we're going to have AP or PA obliques. And sometimes we'll shoot the upper portion of the ribs and the lower portion of the ribs separate. If the patient has a big gut, and on the PA of the ribs, we can see the upper portion, not the lower portion, and we may have to shoot AP upper and an AP lower separately. So patient can be upright, seated, they can be laying down. Again, positional pain, consider the patient's pain, especially if they're upright. If they come to you upright and they've got some significant pain, especially in the back, don't lay them down on their back, it's gonna hurt. right? So consider the patient's pain and their condition. Centering, just like the chest x-ray, 1.5 inches. The top of the image receptor is going to be 1.5 inches above the upper portion of the shoulders. And the orientation of your image receptor is going to be dependent on the patient's body habitus. You know, this says lengthwise, whatever. You know, if the patient is broad, then you may have to do crosswise, and you may have to do upper and lower portion, right? But consider where the patient's pain is. You know, if the patient's clearly complaining of pain in the upper portion of their thorax, you know, from like level of the scapula up, then certainly that's what you want to focus on, that's what you want to see first, right? So put the patient's hands on their hips to make sure that you don't have soft tissue of the humerus over the outer portion of the ribs and give a false positive for pneumothorax. Shoulders should be in the same transverse plane. If the patient's prone, rest their head on and chin on their mid-sagittal plane, keep it, you know, them looking forward. So central ray should be T7, collimated field, 14/17, respiration suspended at the end of full inspiration if we're looking for the upper ribs. Or if you can get the patient on a single image, then it's going to be full inspiration. If you have to take two images, because you got a big patient, you're using the image receptor crosswise, or if you got a patient with a big beer belly and you can't really see the lower ribs well, then what you're going to do is you're going to shoot two. You're going to shoot one on inspiration for the upper portion, then you're going to shoot one on expiration for the lower portion. You're just going to make sure that you've got some overlap in between the two images. So what you may have to do is for the upper portion position, the top of the film, 1.5 inches above the shoulders, and the lower portion, maybe the bottom of the film at the iliac crest, kind of like what you would do for, similar to an upright abdomen. Okay? So, what you want to see is evidence of proper collimation, first through the 9th ribs, kind of like chest x-ray, we want to see 1 through 10. You want to maximize, the difference between chest x-ray and ribs is you want to maximize your contrast. On ribs, you want high contrast. You want it to be very black and white. On chest x-ray, you want it to be very gray. So again, when you're processing, when you select your images, make sure that you don't select chest x-ray for a set of ribs, because you're not going to see the ribs very well, right? So it should look like that. Notice how black and white it looks, and it looks like they did use a minimal breathing technique, and it looks like our density is too high in the lower portion down here. See the way you can't see the ribs at all down through here? So it's a little dark. And imaging, Trina's probably gone on over contrast and density, and it's kind of hard to tell the difference between contrast and density. Because you have to have both, but what we've got here is high contrast because it's very black and white with too much density, right? Because you can't see the ribs. So it's a delicate balance to get to contrast, density, you know, high contrast and adequate density. But overall, it's not a bad set of ribs. You can see the upper ribs very, very well. So again, back to the anatomy itself, we've got posterior ribs go all the way back to the sternum, but notice the anterior ribs only come to right here, right? So I'll point that out for a reason, and we'll get there in a second. So you can shoot them AP, you can shoot them PA. I prefer to shoot mine AP, but the AP ribs are just like PA ribs. You're not going to, you know, appreciably no difference. Okay, so AP ribs is a different patient, but you can still see high contrast, and we get a little high density down at the bottom as well. But where we do see adequate density, we've got very, very high contrast. My mouse may be dying. Okay. So again, if you've got a large patient, sometimes you may have to shoot upper and lower ribs, and that's what we're looking at here. Notice it looks an awful lot like an upright abdomen. So if you've got a large enough patient that you have to do upper and lower ribs, then what you may have to do is use your image receptor crosswise, put the top of the image receptor at the iliac crest to make sure that you've got some overlap between the upper and the lower ribs. So unlike an upright abdomen, you want to include enough of the thoracic cavity as well as the upper portion of the abdominal cavity, so that on full expiration, you can see the bottom of the diaphragm. Okay, so the obliques, the reason I point out where the anterior ribs end is because on the obliques. Your textbook says that if we're interested in seeing, patient's pain is in the anterior ribs, then what we're going to want to do is shoot the ribs with the anterior side up close to the image receptor, okay? Which I would agree with for the PA, but for the obliques, we got some kind of extenuating circumstances. All right, so if the patient's complaining of pain from their axilla forward, then yeah, your PA is better than your AP because it puts the portion of interest closest to the image receptor. But on the obliques, what we've got is the thoracic cavity is kind of like this. It's an incomplete circle. So you take a circle, you break it apart, you got spine back here, and then you got ribs, right? So the ribs don't go all the way to the front because we got that costal cartilage, and then we got the sternum, right? So they go around the axillary portion, which is out to the side. They go around the axillary portion, and then they stop before they truly get to be too far anterior. So your rib cage looks like this. So the bones in your rib cage look like this. Only there's, as many on the posterior side as what there are on the anterior side. So as we oblique, if we are PA, let's say we are PA, and the patient's complaining of anterior rib pain, then we oblique the patient, which side closed up, I'm kind of giving you a hint here, which side closed up and which side opened up. And my fingers representing the ribs, they're pretty symmetric right there, right? Right? Mm-hmm. Yeah, okay. So as I oblique, see what happened to my fingertips, the distance between my fingertips and the palm of my hand on this side? Yeah. They kind of closed up, yeah? And this side really kind of opened up, did it not? So on PA ribs, which side are you going to be interested in seeing? The side closest to the image receptor or the side elevated away from the image receptor? Elevated away, right. So on your AP ribs, we're going to do this opposite direction. AP ribs, if I oblique towards my left-hand side, which ones close up? Elevated side, and which ones opened up? One's closest to the image receptor, right? So in the AP versus PA, generally I would shoot according to the patient's pain. If the patient was complaining of anterior rib pain, I would shoot PA. But on the obliques, I almost always did my obliques AP for that reason, because on the PA oblique, you take the anatomy of interest and you elevate it furthest from the image receptor, as opposed to on the AP ribs, you put the entire rib closer to the image receptor as you oblique the patient. But just know you're going to run into two questions, maybe on this test, and the accepted answer, through the literature, is that if a patient has anterior rib pain, you shoot your ribs, PA or AP? PA, yeah. Yep. Okay, so positioning wise, image receptor is still going to be just like chest x-ray, which is just like ribs, 1.5 inches above the shoulders. For lower ribs at the iliac crest, if you have to shoot upper and lower. The oblique, you can really shoot for either upper or lower. If you don't think that you can fit the patient on an entire image receptor, just one image receptor, then shoot for where the patient's pain is. Most of your hospitals are going to want, on the PA or AP, they're going to want the entire thing. So if you can't fit a patient on a 14 by 17 or even a 17 by 17, you're going to have to shoot upper and lower. On the oblique, you can shoot where the patient's pain is. So if they're complaining of pain lower, then you're gonna shoot lower. Also, you don't have to include both sides on your ribs. Unless I order bilateral ribs, and then you still don't have to include both sides on every image. What I mean by that is because on, let's say, AP ribs, these ribs are gonna be superimposed, right? So are they gonna be diagnostic at all? Probably not. So if you've got a large patient, make sure you get, on the AP, you get the side closest to the image receptor. You know, make sure that you've got plenty of image receptor to include all that. If you clip the upside on the AP, not all that big of a deal. On the PA, if you clip the downside, not all that big of a deal. PA obliques, right? So make sure you get the side that you're interested in seeing, as opposed to, you know, the entire thoracic cavity. So 45-degree oblique, RAO or LAO, or RPO or LPO. On the anterior obliques, we're looking at the side away from the image receptor. Make sure you get the arms out of the way, and you don't have soft tissue overlap. So best thing to do is just put the patient's hands on the hips. Same. So it'll look like that. So this is AP oblique of the ribs. Can't really tell AP or PA. You'd have to see both of them side by side. But notice if this truly is AP, then the elevated side, we've got all this superimposition over here. Notice how small the thoracic cavity on that side looks, as opposed to the side closest to the image receptor. You've got this elongated appearance of the ribs. And that's what you're looking for. You're trying to put this curved rib as parallel to the image receptor as you possibly can. Can't completely succeed in that respect, but the 45-degree oblique gets you as close as you can. Okay. So we've talked a little bit about the possible injuries. So we've got pneumothorax. That's just a complication of broken rib. Flailed chest means that you've got multiple rib fractures on the same side. You can have one rib fracture on both sides, and you don't technically have a flailed chest. The flailed chest is where you've got so many broken ribs on one side, that set of ribs is kind of like mush, so that whenever you inhale, again, you don't have that structural integrity, so the lung collapses and you just can't breathe on that side. That's a flailed chest. Two broken ribs on opposite sides, that's not a flailed chest. Four broken ribs on one side, now you're getting into flailed chest. So that can lead to subcutaneous emphysema, and that's where we've got free air in the tissue outside of the thoracic cavity. And the first time you feel it, you won't forget it. It's pretty nasty. A broken sternum is fairly rare, but it does happen. So a broken rib may lead to a pneumothorax, and a pneumothorax may lead to a tension pneumothorax. All right, so what's a tension pneumothorax? Well, it is where you've got a pneumothorax, and because of the pressure differences between both sides of the lung, what you'll have is a shift in the mediastinum that will then collapse the opposite lung. And then again, you've got a situation where the patient may suffocate. So notice we've got no lung markings over here, so we've got a positive pressure, and it's pushing the mediastinum. You see where the airway is bent towards this side over here. So we've got no air exchange going on over here, and then because of this positive pressure pushing the mediastinum towards the patient's left-hand side, we've got a decrease in that air exchange capability on the opposite side. So again, the patient's really in trouble at this point. So broken ribs, flailed chest. Again, what we've got here is we've got a fracture here, we've got a fracture there, another one here, we've got another one that looks like there. So the integrity of, and here. So he's got no structural integrity on that side at all. This patient looks like they probably have bilateral flailed chest. Most of the time you don't see any kind of plates and screws in in the thoracic cavity. I spent most of my career in surgery, and I never once saw them put plates and screws on ribs, not once. So this had to be a pretty severe case. It looks like somebody probably had osteoporosis, and chances are she wasn't going to heal, right? She just doesn't have the bone regeneration capability to heal those ribs, especially with them moving. So it had to be a pretty bad case, but you know, clearly they do have plates and screws available if they need them. So that's your subcutaneous emphysema. Notice you see a lot of contrast out here in the soft tissue that you normally don't, right? That is probably because we got, you see a chest tube on both sides here trying to reinflate the lungs, so chances are what we have was a nasty pneumothorax on both sides, and it just leaked out. First time I ever saw subcutaneous emphysema was on a patient that she actually had, I don't know how she came about this, but she apparently had some sort of perforation, gastric perforation. And, you know, you've always got gas in your bowel, you know. Any KUB you've ever shot would tell you that. But apparently, I don't know if she had a perforated ulcer or what, but you know, she was complaining of this pain in her neck, and somehow or another it had gotten all the way up into the soft tissue in her neck. So, weird. So sternal fractures can be particularly painful and possibly dangerous as well, because again, to adequately breathe, we need that rigidity in the thoracic cavity, and you're just going to lose it with a sternal fracture as well. Okay? Any questions? Short lecture today. You want Karina to start early? No? Must have a test.
Like 10:40.
Let's see, we usually get out at 10:20, so 10:30. 10:30-ish.
Can she like come in at like 10?
10? You want 10?
Yeah, rather that than like a whole hour.
Yeah. Okay, I'll fill it 10.
Well, even that's like 40 minutes